My talk is about applications of computational modeling in cardiovascular surgery with a focus on how can we gain mechanistic insights from modeling to understand intervention complications and improve surgical treatment. Similar intervention strategies have been employed across cardiovascular systems. One of them is to establish connection between different vessels, such as in arteriovenous fistulas and Fontan procedures. In such interventions, vessels with different geometries and flow characteristics are connected, perturbing the native geometry and hemodynamic loading states. This perturbation may cause a common complication involving neointimal hyperplasia, which has been observed in both AVF and Fontan procedures, affecting their long-term outcomes. Another type of intervention requires the deployment of medical devices such as stent grafts in endovascular repair and artificial valves in transcatheter aortic valve replacement. Unfortunately, leakage complication, including endoleak and paravalvular leak, is a challenge that needs to be overcome to enhance long-term outcomes. The complexity in hemodynamics characteristics, patient or animal-specific geometries, and tissue-specific responses to mechanical loading must be incorporated to link intervention and potential complications. How can we effectively study this link? Ex vivo and animal experiments provide significant insights and understanding, yet they are also highly costly, especially when the effects of multiple parameters need to be considered and isolated. With the increasing amount of clinical imaging, computational modeling approach such as computational fluid dynamics, CFD, agent-based modeling, ABM, can help to build mechanistic insights that link intervention with complications in controlled settings while reducing costs. This talk focuses on two surgical procedures. The first part is on AVF modeling to advance understanding of neointimal hyperplasia, with an implication to understand neointimal hyperplasia in Fontan procedures. The second part is on endoleak in endovascular repair and how modeling can help to identify controlled parameters for reducing endoleak and potentially paravalvular leak. Let's start with the first part where we focus on arteriovenous fistula failure. What is an AVF? It's a connection between artery and vein to provide an access point for dialysis. The AVF perturbs the native hemodynamics pattern by connecting the high-pressure pulsatile flow in the artery to the low-pressure constant flow in the vein. AVF patency and freedom from intervention decrease long-term, posing a challenge to better understand the consequence of hemodynamic perturbations. I will present how we use CFD to better understand the hemodynamics in this system and its link to AVF failure. The results in this talk are mainly from our collaborative work with Dr. Vasanik, Dr. Bosivapsaks at Chicago, and Dr. Dadik at Yale University, recently submitted to Physics in Medicine and Biology. AVF failure is associated with perianastomotic neointimal hyperplasia, or the thickening of the vessel wall over time, leading to the close of the lumen. Yet, the link between hemodynamic changes, especially the spatial gradients of hemodynamic factors such as velocity and turbulence along the vein, to neointimal hyperplasia remains unclear. We propose to build a validated CFD model of AVF and link with cellular responses to gain mechanistic insights into how neointimal hyperplasia is formed and how is it linked to the spatial gradient of flow dynamics in the vein. In order to develop our CFD model, we need to construct highly accurate AVF geometries. Here we build a global geometry by using CT image of in vivo aorta cava fistula in murine model. As shown here, the vein in blue, artery in red, and the fistula connection in yellow are segmented with high precision to establish the AVF model. For CFD, we need to prescribe the precise boundary conditions to model the realistic model. Thus, we obtained ultrasound measurements in the murine model for the arterial inflow and venous inflow and use them as the boundary conditions in our CFD model. With a precise input from experiment, our CFD model can predict the flow pattern and spatial gradients of the hemodynamic factors in the AVF that are not easily accessed by experiments such as velocity and turbulence. In this talk, we will focus mainly on venous turbulence profiles. Our CFD model is able to predict the gradient of turbulence along the vein with a significant increase in the turbulence intensity in the perifistular regions. The amplification of turbulence is more significant in diastole comparing with in vitro ultrasound color Doppler images of flow in the vein and artery above and below the fistula, as well as in the perifistular regions, where red and blue indicates flow towards and away from the ultrasound transducer, respectively. We observe similar turbulence behavior as predicted in CFD. This further confirms that we have successfully constructed a CFD model that can capture the complex flow dynamics in the AVF. Again, CFD provides a more detailed gradient map of how hemodynamic parameter changes as compared to the targeted snapshots of the measurement in vivo. How do the spatial changes of gradient of hemodynamic parameter in CFD model connect to neointimal hyperplasia? We compared with histology images and observed an increase in the thickening of the vein in the perifistula in parallel to CFD velocity and turbulence profiles. What is the underlying mechanism for this parallel? To understand the link between hemodynamic venous parameters with neointimal hyperplasia formation, we developed an agent-based model to integrate the cellular response induced by hemodynamic perturbation. First, as shown in the figure A here, the venous turbulence intensity at each cross-section of the vein will be extracted from CFD. Second, as shown in the figure B, ABM will be initialized by discretizing the cross-section using a lattice mesh where each cell is associated with a turbulence value for the cell on the wall of the vein. Two types of agents representing endothelial cell and vascular smooth muscle cell are seated with endothelial cell in the innermost layers, as shown in the star symbol here, while the circle symbol represents VSMC cells. How do the cells respond to the turbulence profiles? We hypothesize that EC will degrade when the turbulence reaches a critical value. VSMC cell will then differentiate following EC degradation to thicken the vein wall. To test this hypothesis, we developed two mathematical probabilistic rules to describe these two cellular processes. We assume that the degradation and differentiation are governed by two probability functions. Each function is determined from the turbulent state and its value ranges between 0 and 1 as shown in the red and blue curves here. As degradation and differentiation are probabilistic, at each time step, these probabilities will be compared to a random value to decide whether EC degradation and VSMC degradation occur or not. We also utilize an age restriction to limit the excessive degradation and differentiation over time. These two rules are shown here in the schematics. To visualize how these two rules work, we provide work on the right side here of on figure D show like step by step the degradation process and differentiation process of VSMC cell. More details can be seen in our manuscript. So with the incorporation of the two probabilistic function from the CFD profile of turbulence, we can model the growth differentiation of our ABM model. Our ABM simulation presents the thickening process in the vein due to the cellular pathway. If we further compare the thickening of the wall from our model with histology in A and macrocity in B and in terms of good agreement, this suggests that our one-way coupling CFD ABM model reflects the neo-intimal hyperplasia gradient seen in the mouse. The computational approach that we have applied to study AVM can also be conveniently applicable to study interventions for congenital heart disease. For example, previous work has shown that CFD can accurately capture the fluid dynamics in Fontan procedure. This figure compares the flow field between CFD simulation with MRI for 3 different patients. The good agreement between them further confirms the utility of this computational technique. What we can do with such understanding of hemodynamics in Fontan procedure. This is where our approach of coupling CFD and ABM to further connect hemodynamic changes induced by surgical intervention with complications such as neo-intimal hyperplasia would be an interesting direction for further work. We recently published a review of various applications of CFD for congenital heart disease. If you are interested, please refer to our collaborative paper with Dr. Posivavsek and Dr. Hipino at Chicago. So we have developed a validated CFD model for AVM. We also shown that our model successfully predict the gradient of hemodynamic parameter that is parallel with neo-intimal hyperplasia. The one-way coupled CFD ABM developed in our work can test the hypothesis that the cellular mechanism connect spatial hemodynamic changes with neo-intimal hyperplasia. Next, I will focus on the endolytic problem. How can we use computational and analytical insight to understand what are the controlled parameters that can be intervened to reduce endolytic during interventions? At the end, I will briefly connect with paravalvular leak in transcatheter aortic valve repair. After endovascular repair, ideally, blood should flow only inside the stent. However, endolytic complication where flow leaks between the stent aorta interface persists. Clinically, surgeons attribute several factors including neck length, aortic curvature, degree of oversizing, pressure gradients to be critical drivers of endolysis. However, currently, due to the empirical nature of such understanding, how to minimize endolysis remains uncertain. In this talk, working together with Dr. Dara and Dr. Bosivavsak, we look at integrating computational modeling, theoretical insights to address this uncertainty by building a scientific foundation of what factors affect endolysis and how. In order to better understand endolysis in complex patient-specific geometry, we first take a step back and analyze shear zone established between a stent deployed in a simplified aortic geometry, where we can develop both theoretical and computational models to explore the physics of the problem. Ideally, the stent should fit perfectly in the inside radius of the aorta as two perfectly fit concentric cylinders. However, when we deployed a rear stent inside a perfectly cylindrical reconstruction from micro-CT shows a corrugated stent pattern. This corrugation gives rise to the endolysis occurrence where the blood can flow between the gap of the aorta stent interface. So what factors and how blood can flow into affect how blood can flow into this potential gap space? In other words, how can we know the impact of empirically and clinically relevant parameters, oversizing, shear zone geometry, and hemodynamics on the risk of endolysis? First, let's consider the case where the uncompressed stent is idealized at a perfect cylinder. The stent is deployed into a smaller aorta to study the impact of stent oversizing, where the oversizing is the relative difference between the circumference of the stent and aorta. The corrugated pattern is simplified into a wrinkled pattern with well-defined wavelength lambda and amplitude A, both of which are dependent on how much the stent is oversized. Specifically from our previous published work on wrinkled systems, we can explicitly relate wrinkle wavelength and amplitude to the oversize. This is very powerful as we can then relate to the endolysis in a quantitative manner. Before that, we will need to construct methods to determine the flow rate through the wrinkled interface, and CFD is a perfect tool for this. Applying our expertise in using CFD to study AVF in part 1, we were able to construct CFD simulations for this problem, as the gap can be very small, so note that we will need to carefully resolve the mesh in the gap region to accurately capture the flow field, from which we can determine the flow rate Q and conveniently study the impact of important parameters, oversize, pressure gradient, wrinkle geometry. We constructed parametric study where we varied the wrinkle wavelength and amplitude as well as pressure and viscosity of the fluid. On the left side is a variation between Q and amplitude A for different wrinkle number and pressure gradient, while the data shows that the increase in the wrinkle amplitude leads to an increase in flow through the gap. The data is also highly scattering. How can we better understand this data and the correlation between the parameters? To do this, we used the theoretical insight for flow through an annulus. We suggest that Q should depend linearly on pressure gradient delta P. Interestingly, this helps us to significantly collapse the data, especially in the regions of not too large amplitude, the region where the assumption of the theory holds. The figure on the right replots the data by applying this normalization with delta P. Let's look further on this renormalization. The slope of the data is also consistent with the cubic dependence on the amplitude further suggests that the flow through the gap varies scale cubically with the amplitude, linearly with the pressure gradient. Now, by linking back to the connection between amplitude to wavelength and oversize, we can specifically develop a quantitative relation that describes how the flow depends on wavelength, oversize, pressure, and viscosity. Note that while we don't show the viscosity in the previous slides, we did a similar parametric study varying viscosity to study its effect. This is a very powerful relation and it explicitly shows how much each parameter has an effect on Q. Our question now is whether this can be generalized to more complex geometry. For that, we went back and performed a very detailed CFD simulation using the actual corrugated pattern of the stance. The flow field is highly complex. However, we can accurately get an average of the amplitude and the corresponding flow. In this case, the amplitude is around 0.55 and the normalized Q is 0.12. The idealized model at the lower and higher amplitude actually provide lower bound and upper bound for this complex flow field, suggests that the ideal model can give significant insight into the flow field into a highly more complex geometry. So how can we reduce the flow rate Q, which is critical for preventing endoleak? Our results show that there are multiple ways we can intervene. First, we can reduce the level of oversizing. A clinically available procedure is the use of endoanchor to increase fixation without the need to depend only on oversize. We can also adjust the shear zone geometry through reducing the corrugation wavelength. Clinically, we can think about this as designing stand with material and geometry that can be more compatible with the aortic curvature to reduce corrugation. And hemodynamics such as pressure gradients and viscosity are clearly important in deciding endoleak. We can control blood pressure and through blood thinner to control these parameters. The insights and approach presented here can also lead to enhanced understanding in other problems such as paravalvular leak, CFD simulation. Therefore, are important in guiding surgical procedure to the risk of unwanted outcomes such as leakage. Not only model leak, but the development of leak through neck degeneration or valve deforming, moving beyond elastic response to incorporate biological response interaction with complex flow will be another interesting avenue to explore in the future work. So with that, I would like to thank our collaborator and if you have any questions.